Hello and welcome everyone. Good morning, good afternoon, or good evening. Thank you for joining the Dirui webinar from different parts of the world today. My name is Yuru Lin, and I'm the academic manager at Dirui Industry. I will be the host for today's webinar. Today, we will focus on raising awareness about kidney health and the application of different diagnosis parameters. Before we start the lecture, let me briefly introduce Dirui. Dirui has been held by China Resource Industry Fund since 2020. The CR Group was established in Hong Kong in 1938 and is one of the first official state-owned capital investment companies in Hong Kong and in mainland China. In 2023, CR Group is ranked 74th among the Fortune 500 companies. There are 6 key business areas in CR Group. Dirui is the only one business unit that focuses on in vitro diagnosis in the healthcare sector. Now let's take a closer look at Dirui. Dirui was founded in Changchun, a city in northeastern China in 1992, as a leading IVD company. Dirui's products are trusted by more than 14,000 medical institutions in China and users in over 120 countries and areas worldwide. This accomplishment has been possible due to our extensive and diverse product portfolio. Many of our friends know Dirui through our urinalysis analysis, but actually we had 8 product series in 7 different fields. Our products can cover more than 80% of clinical testing items. This allows us to meet clinical needs at all levels, providing a complete IVD solution. By offering a wide range of products, we are able to achieve our mission, which is to popularize diagnostics and benefit the masses. With that in mind, let's back to today's webinar agenda. As Dirui starts with urinalysis analyzer, it still remains our most well-known product. Based on our expertise in urinalysis, we hold today's webinar in nephrology landscape. Today, we will start with Professor Christoph Warner. He will discuss the impact of chronic kidney disease from a nephrologist's perspective. Following him, Professor Joris Delenham will explore the application of protein markers in the assessment of kidney disease. After the lectures, we will have a Q&A section. So please don't hesitate to submit your questions during the presentations. The professors will reply to the questions afterward. Let's begin by introducing our first speaker, Professor Christoph Warner. Dr. Warner is a senior professor of medical at University Hospital of Würzburg and a visiting professor of renal medicine at University of Oxford. His research in the field of diabetic kidney disease and lipid disorders has been published in more than 1,000 PubMed articles. Professor Warner's 2 landmark studies in this field have been published in 2005, the 4D study, and in 2015 and 2016, IMPAREG outcome. Professor Warner is the immediate past president of the European Renal Association. Please join me in welcoming Dr. Warner.
Thank you, Claire. Very, very kind of you.
So please start your letter.
Okay. First of all, you gave me a very interesting title, and I thank you for this. Challenging, but I will go across my transparency declaration with companies working in the field of large clinical trials. And then I had an initial slide on the snapshot. What is chronic kidney disease? So chronic kidney disease, or CKD, is defined by an injury marker and a function indicator. And injury marker is urinary albumin creatinine ratio. And the estimated glomerular filtration rate, GFR, is the function indicator. So then you see that the worldwide prevalence is quite high for chronic kidney disease. And then US has some good data, so I picked it here, depicted US prevalence. Kidney failure, the new word for end-stage kidney disease, is irreversible and defined by people going to a treatment, kidney replacement treatment, dialysis or transplantation. And we have about 3 million transplant and dialysis people worldwide. So this is a cartoon showing the two main components in the blue boxes: urinary albumin to creatinine ratio in milligram per gram, and on the left-hand side, estimated glomerular filtration rate. You see the stages of chronic kidney disease from normal kidney function, 100% or 100 milliliter per minute, down to kidney failure below 15 ml per minute. And the colors indicate the risk. Red is very high risk to progress to cardiovascular disease and to kidney failure. And we do these two tests, UACR and eGFR. And I depicted here a very recent publication saying the first box is all-cause mortality. 26 million people are behind this box. In the middle is myocardial infarction. On the right-hand side is heart failure. On the bottom left is cardiovascular mortality. In the middle bottom, stroke, and right peripheral artery disease. And this test is not only indicating kidney failure, but also the cardiovascular risk. Very new, important data. So we go again to this explanation. Why? Because high albuminuria is associated with a higher risk on the left-hand side to develop kidney failure or end-stage kidney disease. You see on the left-hand side, on the bottom, the albumin creatinine ratio. Above 30 is elevated, and from there starts the risk. The higher the ACR, the albumin excretion, the higher the risk for developing ESKD. On the right-hand side, you see that cardiovascular death is already starting in the very low range of albumin creatinine ratio. And when it's about going above 30, then you already have a 1.5 elevated adjusted hazard ratio. And these are lots of data which accumulated over the last 10 years. Next slide here is chronic kidney disease and type 2 diabetes. So special subpopulation, again, high risk of cardiovascular death. And on the left-hand side, you see the lower the eGFR goes, the higher the risk is. On the right-hand side is the higher the UACR to the right is, the higher the risk in type 2 diabetes. And this risk starts again on the left-hand side when the GFR is below 75 already, and on the right-hand side when the UACR is above 5 milligram per gram. So very, very healthy population with longevity. They are all above 65, 75, and below 5. So we talk about two different things in medicine: retarding progression to dialysis And in many places of the world, you want to maintain kidney health as well. Depends a bit on the culture. So here, a textbook cartoon known since long. You start with type 2 diabetes. You have a renal function of about 135%. And then you start in the early days to hyperfilter, the blue line. Your kidneys are overworking until a certain number of time, normally 15 years, occurred. In about half of all type 2 diabetes patients, the GFR declines towards dialysis, and this is called the slope. At the same time, urinary albumin is excreted. And look at this draft. Early on, determination of urine albumin can early on tell you the risk that the patient is going to kidney disease. So here is how the nephrologists are thinking. Since 20 years, look at this paper. Paper is very old. We think about a type 1 diabetes here, diabetic patients, 25 ml, 25 years old, and 100% or 100 ml kidney function. And this patient is progressing by 5 ml per minute per year. And what we want to do, every doctor, everybody wants to push up the line that the glomerular filtration rate maybe is not declining as fast and the patient never goes to dialysis. And clinical chemistry, and we hear this later, will provide us the GFR and the albumin test. But nephrologists see the patients very late because the disease is without pain. So the question always is, what can we do when we see the patients late? So we would like to ask every general practitioner, every doctor, when he's seeing a patient, do annually GFR, and you can construct this slope. So the question is next, have you seen the elephant in the room? The elephant is the kidney test, and the kidneys are not very much looked after. All people look at the heart, the brain, the lungs, but not at the kidney. There is a lack of diagnosis, a lack of missing screening or missing screenings. And we tell our students always before the treatment, there is a diagnosis. So diagnose the disease that you can treat it. And diagnosing means here is the A and the E. The A is albuminuria and the E is eGFR in high-risk groups once per year. On the left-hand side, you can see again the stages of glomerular filtration rate. You can talk your patients. You say you have 50 ml, you have 50% kidney function. And on the top, you see the albuminuria. But you can also see a blue box. And the blue box is normal kidney function, GFR above 60 to 90, which is normal. But blue box is already kidney disease as an early stage with normal kidney function. You see that the albumin excretion is already elevated. So you have to do albuminuria tests to find out the kidney disease. And doctors don't use it. But when you use it, then you can see with UACR that the patient, the speed of the patients traveling to the cliff, and the cliff is dialysis. High UACR, high speed. With the eGFR, you can only see the position the train or the patient is in the moment, in his point of time in the life. But UACR, together you have the feeling about the progression rate. So we did a study in Germany, in SPEC-CKD. And you see on the left-hand side, we have a large sample size, 448,000 patients from 1,200 general practitioners. 35% worked as internists, 65% as general practitioners. And they have in their outpatient clinic, we just downloaded everything they had in their database. You see that people in Germany in GP's hands are 65 years old, have high body mass index, have suboptimal blood pressure, and half of them are women. But many who go to the doctor have arterial hypertension, cardiovascular disease, diabetes, and 1 out of 10 or 75% have high risk, have everything. And we observed these people for 1.7 years. And what we found is, and I now show you the diabetics, the highest risk only, not the 400,000, but now the subgroup of 145,000. These doctors, they do GFR in 50% only once during the observation time. They do dipstick in a fifth, and they never use UACR. And UACR is guideline. So you should be better. And Professor Delange will later on tell you how to do and how to interpret. So the general practitioners in Germany, they ask 5 questions. And now you listening to us, can you answer me the 5 questions? When do I sample? Where do I send the sample? What does it cost in your country is always important. Then who is paying? And what does it mean? So the answers are, and maybe you know it, you sample in the morning spot urine or in a spot urine any part of the day, morning preferred. You send it to the central lab. In Germany, you pay €3, different in other countries. Insurance is paying in our country, and the doctors do not know this. And what does it mean? I showed you the cartoon. So there is also a discussion in the world maintaining kidney health, not waiting until the patient is on the slope. So there was an international conference, Kidney Disease Improving Global Outcome Controversies Conference in Rome half a year ago with the European Renal Association. And they felt maintaining is exactly keep the patients in the healthy box. And there is a paper in JAMA explaining this also. So keep the patients healthy. And how to do this? And I tell you some examples. You have to define individuals at risk. You cannot look across the entire population. And 3 categories that define early risk for CKD are metabolic diseases, familial diseases, and in the future, maybe also environmental. So you see, number 1 is type 2 diabetes, morbid obesity, the women who have gestational diabetes, or the men who have prediabetes, intrauterine adverse child conditions in families easily to be detected when you draw a family, a pedigree, a high blood pressure, preeclampsia, and in the future, some toxins as well. The kidney has to be looked after in these risk people. How can you do this? Examples of protecting the patient. We have 4 foundational therapies today, and we have 4-pillar approach. And these are the foundational therapies: RAS blockade, SGLT2 inhibitor, non-steroidal MRA, and GLP-1 receptor agonist. All these treatments have large randomized trials have proven to protect the kidney. And the question is, do you need them all? Most likely in many patients, yes. One example from the EMPA-REG outcome, 7,000 patients with glomerular filtration rate. These 7,000 patients had cardiovascular disease, no kidney disease, and they progress by 1.8 ml per minute per year. And if you give them empagliflozin, an SGLT2 inhibitor, then they only progress by 0.3. So people with type 2 diabetes, no kidney disease, but cardiovascular disease, you can protect them and you can nearly bring them to 0. And the important thing is they all move to the right. They all are protected. And this is a low number needed to treat. And if you look at those who have no albuminuria or have A1 or A2 macroalbuminuria, you can see that albuminuria drives the progression. And those with macroalbuminuria, they go by 7 ml per minute per year in 5 years to dialysis. An example from EMPA-KIDNEY. On the left-hand side, the EMPA-KIDNEY study had 7,000 people, and the placebo group progressed by 2.75 ml per minute per year, diabetic and non-diabetic kidney disease. And with empagliflozin, you could bring them down by 50% progression. On the right-hand side, 3 categories of albuminuria. Those on the right, far right, with macroalbuminuria progress by 4.11, and you protect them by 43%. If you go lower, and if you go to early stages where they have no albuminuria so far, then you can protect them even higher by 88%. And what have we achieved in the last year? When we look at EMPA-KIDNEY and DAPA-CKD, here is now a type 2 diabetic, 63 years old, 50% kidney function only, and elderly, and with dapagliflozin or empagliflozin, look, you can protect these people going to dialysis. So we can do something, but you have to diagnose the people. So what is the problem we are trying to solve? My final slide. Half of all people with chronic kidney disease have diabetes, but only a minority survive to reach dialysis because most people with diabetic kidney disease die of heart failure and atherosclerotic cardiovascular disease. You can avoid dialysis with this medication, but you also can avoid cardiovascular events and provide quality of life. And I was looking at the New England Journal paper just 4 weeks ago, the FLOW study authors with the GLP-1 receptor agonist, they said clinicians and patients will need to consider the order and priority use for semaglutide, for example. So the first time that I read prioritization, you doctors out there, you have to diagnose and then give them the right medication. And the prioritization, my opinion is SGLT2 inhibitors are for kidney outcomes in heart failure. Finerenone, the non-steroidal MRA, is good for both kidney and cardiovascular outcomes. And semaglutide is stronger on cardiovascular outcomes, but also protects a bit of kidney deterioration. So I think this was my overview. Again, I remind you, before the treatment, there is a diagnosis, and I handle over back to the moderator, to Claire. Thank you.
Thank you, Professor Wander, for the informative presentation. It clearly shows that the importance of the testing in management the kidney health. Thank you for your lecture. Please, now it's on my screen, okay? So for our audience, if you have any questions, please feel free to use the Q&A function to submit your questions. We will address your questions during the Q&A session. Now let's move on to our next speaker, Professor Joris Delahaye. Professor Delahaye's current position is Professor of Clinical Chemistry at Ghent University. He's the editor-in-chief of Clinica Chemica Acta. It's an official IFCC journal. He studied medicine at Ghent University and specialized in laboratory medicine. And he obtained his PhD afterward in clinical chemistry. His research focused on plasma protein chemistry, urinalysis, and diabetes. He has published over 620 scientific papers. So he was the past president of the Belgian Society for Clinical Chemistry, and now he's the member of the FCC Committee on Kidney Disease. Let's welcome Professor Delanhead. Hello, Professor Delanhead.
Yes, good morning. I'm trying to share my screen.
Okay. Take your time and we look forward your lecture.
Thank you very much for your kind introduction. As announced, my talk will deal with protein markers in the assessment of kidney. So my talk will essentially have 3 chapters. The first one will deal with EGFR and with an emphasis on cystatin C. The second one will deal with alpha-2 macroglobulin, and the third one on alpha-1 microglobulin. So first of all is the chapter dealing with EGFR and cystatin. So we know that, as already introduced by Professor Warner, the GFR plays a very important role in the assessment of chronic kidney disease, and it's basically based on 2 pillars. The GFR determination, mainly used by creatinine, and the microalbuminuria. We know that GFR is a very important prognostic factor, and it plays a key role, as already pointed out by Professor Warner. So chronic kidney disease is a very important public health problem. Although it was only mentioned for the first time in 1999, we are now aware that about 11% of the population has CKD. The key question is, how do we measure glomerular filtration rate? Theoretically, we could go for exogenous markers like inulin clearance, but they are no longer available, so the out of the question. So the alternatives, both non-radioactive and radioactive exogenous markers, here we see that the availability of these markers is very limited. Certified reference materials for iohexol and iotalamate simply do not exist. So we are running into trouble, and there is a strong need for an endogenous filtration markers based on a single blood collection, which should be as accurate as MGFR without correction for other variables. So for 1 century, we have been relying on creatinine. Creatinine is the hydrolysis product of creatine, and mostly the analysis relies on a paper dating from 1886. Although it's often referenced, this paper does not deal with a method. It's only a precipitate which has been observed by Mr. Jaffe as early as 1886. In consequence, we see that there is a lot of problem. First of all, creatinine is not an ideal GFR marker, since we know that it has been partly secreted by the tupils. So people have tried to adapt creatinine clearances towards GFR, and is a long way since the pioneering work of Redberg in the 30s. So we now have come to a number of practical formulas dealing with eGFR calculations or estimations, which do not rely on the prelevation of urine. However, the Achilles heel of the entire system is the lack of standardization because there is simply not a reference publication written by Mr. Jaffe. And you see that in practice, we see that about all variables that are modifiable are indeed subject to variation when you look at commercial vendors. And in the meantime, there has been a thorough change in the analysis of creatinine that we no longer used native serum. And this implies that we now are using native serum instead of deproteinized serum. And this means that the protein error got into the determination, and unfortunately only reference values have been adapted, and physiology books derived formulas do not longer match with what is happening in the laboratory. And of course, all studies dealing with pharmacokinetics of commonly used drugs are no longer valuable. A next problem is, of course, the hyperbolic relationship between serum creatinine and the GFR. We see that this is a very nasty problem, and moreover, due to the physiological variation in muscle mass, we see that reference values for creatinine are very broad. And this makes it very difficult to make precise estimations in the so-called blind range. So we know already that classical creatinine clearance is often difficult to carry out in practice, and we know that therefore these more practical approaches are getting more and more popular. The most classical one is the formula of Cockcroft and Gold. It should be mentioned that Cockcroft and Gold never have calculated GFR, but creatinine clearance, it's not the same. And their formula is based on body weight, on serum creatinine, and on the gender of the patient. It goes without saying that 1 kilogram of muscle is not the same as 1 kilogram of fat, and therefore, there in patients with high or low body mass index, the Cockcroft and Gold equation is no longer to be recommended. Moreover, in view of the standardization issues, the Cockcroft and Gold data no longer fit with the present day creatinine results which are provided. More important is the MDRD equation, which has been introduced and which also contains a race factor for Afro-Americans. We see that the Cockcroft and Gold formula is getting more and more abundant because of the introduction of the global standard, the NIST 967. And this means that since 2009, all methods are supposed to be calibrated according to an IDMS reference measurement. The key problem is, did we solve all problems? No, it isn't, because the remaining physiological variation remains, and we see that even a perfect creatinine assay does not solve the problem completely. We see problems in non-adults. For infants and children, we need an adapted equation, Schwarz equation, which is only valid for enzymatic measurements. Individuals with unstable creatinine concentrations, very common in our hospitals, they are difficult to get their GFR measured. And of course, cases of extremes in muscle mass and diet. So, calculated GFR methods are the standard. MDRD is gradually has been replaced by the CKD EPI formula, which has an extended application. We see that only two coefficients are in use, Afro-Americans and others, which is a very American-centric view on the world, and which is, of course, not as universally applicable. What we do see is that the various formulas which has been published over time, we see when we compare them that there is a far from standardized answer. Here you can go to the internet, you simply key in the demographic data of a patient, and you see that depending on the formula you are choosing, you can get all answers you want. And Cockcroft and Gold in this case tells you the clearance is 57 and MDRD is 87. It goes even worse in other cases where you see, for instance, in this 52-year-old with ascites, that you can sweep the GFR from 47 to 111, which is very, very, very confusing for clinicians. And so we see that the largest discrepancies will occur in the older age groups, where, of course, the muscle masses are not so typical, and you see that there is a lot of error. These errors, we heard Professor Wanner that it's important to assess the slope of the GFR in function of aging, but we should also keep in mind that the relative error of our estimation is not as good as many of us think. Although some labs report with a precision of 0.1 milliliter a minute, we see that in reality, the error may be as high as 30%, both for CKD epi and MDRD. And so even the choice of the formula has a big impact on the classification of our patients. So the situation is not as clear-cut as we would like to be. And it is clear that neither the CKD epi nor the MDRD study equation is optimal for all populations and GFR ranges. And the problem is real, which is illustrated by this dramatic figure that 15% of beds in Swedish hospitals, Sweden is a country with a very advanced healthcare system, are occupied by patients showing drug overdoses, often caused by an unknown GFR reduction in age patients. So the question is, what the situation now? It's even worsening because of the situation in the US, where the George Floyd case has introduced fierce public debate, and now people in the US are pleading for a race-free formula. Introduction of such a race-free formula, which is a compromise, in fact, would, for instance, mean that the number of CKD patients in a country like Denmark, with very little proportion of people from African descent, would go down by 24% abruptly. We shouldn't forget that these formulas are made for identifying patients at risk for CKD, and they are not meant for drug dosing. So I hope you are convinced that there are a number of problems, and which alternatives do we have? Cystatin C is very well documented. In contrast to creatinine, cystatin C is produced by all cells. It's a small protein and is characterized by glomerular filtration. The reciprocal value of its concentration is proportional to the GFR, and it's non-depending on muscle mass, which is a big advantage as compared to creatinine. We don't require any urine prelevation, and there is no blind range. Remember, in the range between 60 and 90, we see that for creatinine, there is a big problem, and we see here a very flat curve, which is not the case for cystatin C, where we have a much lesser blind range. Also, it should be noted that the age dependency of reference values of creatinine is much less as compared to cystatin C. Here we have a very stable reference range, and it can be used from the age of 1 year onward, which is another advantage for cystatin. Cystatin C, in parallel to the MDRD and CKD epi formulas allow to calculate the GFR based on the serum cystatin C concentration. Also, the IFCC has managed to produce a new globally accepted standard so that analytical issues no longer are the case. So, of course, 4 years ago, the George Floyd case has thoroughly changed the world of EGFR testing. This has initiated a strong debate where in the US, the use of creatinine and its race dependency has been questioned. And in that case, of course, cystatin C plays a very important role. I am not pleading for a systematic replacement of creatinine by cystatin C. This would be a very high financial burden, although we can expect that price erosion will bring down the pricing of cystatin C. But as I pointed out, the great number of problem cases that cystatin C might be very useful in solving problem cases. For instance, children, patients with an atypical muscle mass, or doubtful cases. So this should rethink the position of specific proteins in urinalysis. And the availability of sensitive immunoassays has made the determination of specific urinary marker proteins attractive for diagnosing nephrological and urological condition. So next to cystatin C, we should pay attention to alpha-2 macroglobulin. We know that hematuria is a common problem in nephrology and urology, and the differentiation is not always that easy. We can distinguish renal causes of hematuria and post-renal causes of hematuria. So hematuria may be due to a large variety of diseases. And traditionally, since the landmark paper written by Birch in 1983, we know that the differentiation of dysmorphic and eumorphic cells plays a key role. This is difficult because there is no standardized definition of dysmorphic cells, which makes the inter-observer comparison a little bit difficult. We can theoretically use machines, for instance, urinary flow cytometry, but these are based on algorithms which are based on RBC size. And we know that RBC size is also affected by other parameters such as osmolality and the iron status. And we see that dysmorphic cells can be present under a large variety of morphological forms, and we know that they are affected by both pH and osmolality. So even machines have problems in finding dysmorphic cells, and this makes the problem difficult to solve from an analytical point of view. Alpha-2 macroglobulin might be considered as a very interesting alternative. It is a huge protein, 720,000 is its molecular mass, and it means that it can only enter urine when the blood vessel is leaking into urine. So in other words, it's an ideal marker for detecting postglomerular hematuria, since presence of alpha-2 macroglobulin is not due to a nephrotic condition, but due post-glomerular hematuria. It is an alternative marker, and we see, for instance, that in cases of hematuria, we can easily distinguish post-glomerular bleeding, characterized by a high concentration of alpha-2 macroglobulin in urine, from the classical glomerular causes of bleeding. As a third chapter, I will deal with another protein, which is a small one this time, which is alpha-1 microglobulin. We know that protein electrophoresis may show a large variation of patterns. The most commonly observed are the glomerular patterns, here a selective, here a non-selective one. But we see, for instance, in this case, we see other proteins appearing which cannot be seen in a glomerular type of proteinuria. These are microproteins. Microproteins, they are appearing in urine when the tubular absorption fails. So we have a new group of urinary biomarkers which appear in urine when the tubular reabsorption fails. Tubular proteinuria originates when tubules have a diminished capacity to reabsorb and catabolize proteins. So we do have a number of microproteins in which alpha-1 microglobulin is very promising one. In contrast to the previously used beta-2 microglobulin, which is an unstable protein, alpha-1 is very, very stable over a wide pH range, and this allows to diagnose urinary tract disorders. For instance, early detection of tubular disorders, nephrotoxicity, drugs, diabetic nephropathy, outflow disorders, and pyelonephritis. Here we see that the glomerular filtration, glomerular proteinuria has an entirely different mechanism from the tubular proteinuria, and we see that alpha-1 microglobulin is very stable in acid urine. It is and has been made possible by the advent of easy automated routine immunoassays. An increased excretion may point towards intoxication, pyelonephritis, vesico-urethral reflux. Unfortunately, alpha-1 microglobulin is still subject to standardization efforts. What can we do? For instance, the differentiation between lower and upper urinary tract infections has become easier when introducing alpha-1 microglobulin. In the case of upper urinary tract infections, we can simply make a distinction with the lower UTIs, cystitis, by measuring the alpha-1 microglobulin concentration. When it's exceeding about 10 milligrams per liter, the diagnosis of upper urinary tract infection, it gets likely. So see that the RRC curves for alpha-1 microglobulin are excellent and much better than, for instance, the more classical pathological casts. So it can be used for differentiation of UTI. It's a very sensitive marker for tubular dysfunction, although here we have some competition with renal tubular epithelial cells, which can be distinguished in sediment analysis. Urinary proteins, so we can make this summary. Microalbumin is, of course, the marker for glomerular damage. It's been very useful in monitoring diabetes. Alpha-1 microglobulin detects tubular lesions and may be useful in differentiation of upper from lower urinary tract infection, metal intoxications. For instance, whereas alpha-2 macroglobulin is a hematuria differentiating marker. Here we see, for instance, the use of alpha-1 microglobulin for distinguishing, for detection of vesico-urethral reflux. We see that a nice correlation occurs between the detrusor pressure and the tubular damage. So it's an indicator of the damage caused to the kidney. Here we see that the degree of vesico-urethral reflux nicely corresponds with the alpha-1 microglobulin concentration in urine. And here we see the distinction between the glomerular pathology, the red squares on the right, the faint colors represent the tubular, pure tubular proteinurias, whereas the yellow circles represents the interstitial pathology. How can we still improve our diagnostic accuracy? By introducing dilution parameters. They're strongly underused, and they allow to correct the result for dilution. Which choice do we have? We can have the choice between creatinine, present on modern strips, specific gravity, which is also present on the strips, or on urinary flow cytometers, conductivity, which is inbuilt in a number of machines, and osmolality. These dilution parameters can allow us to correct results for dilution. They're not identical. Osmolality is the most expensive one and a very good one. Creatinine is largely sufficient for the largest majority of cases. Specific gravity measures the sum of charged and uncharged particles, can be hampered in case of presence of iodinated contrast media. Urinary conductivity is not sensitive for glucose. So what can we state? That due to the improving analytical performance, we see that CV values strongly are decreasing over time. And this means that our attention should be more focused on the pre-analytical phase. In that case, European guidelines recently published are important. They are okay, but not always as practical. For instance, in pediatrics, geriatrics, intensive care patients, patients with catheters, etc. So the future of urinalysis will be an integration, no doubt about it, since we have a growing palette of test possibilities. We will need integration of urinalysis, and in that sense, we will probably need the use of AI for improving our diagnostic capacity and the development of expert systems. So this will allow to maximize information content and to integrate existing technologies. So I hope I've been able to convince you that urinalysis no longer has this outdated character like depicted on old paintings, but in contrast, we will jump ahead with a quantum leap, and we will enter a new era of urinalysis. The last slide, I only wish to thank my collaborators for helping me in assembling this information. And I thank you very much for your attention, and I'm willing to take your questions.
Professor Delanhans, thank you for your insightful presentation. Now let's invite Professor Warner to join us for the Q&A session.
Okay, thank you.
Hello, Professor Warner. And we've checked our question box, and thank you all for your questions. We have selected 2 questions, each for Professor Warner and for Professor Delanhans to answer. And we will start from Professor Warner. The first question is, could you share your views on the clinical significance of laboratory tests that relate to kidney disease?
Yeah, thank you. You know, very important. Without laboratory test, the nephrologist and every doctor is lost, because the kidney disease is silent and does not cause pain. And the patient is not aware of kidney disease unless in very late stages where you develop edema or other signs and symptoms. So to detect kidney disease, laboratory tests, as we have seen and heard, are very, very important. Yeah? And we should use them for screening in high-risk population in the international guidelines from the American Diabetes Association, from the European Society of Cardiology, from KDIGO, from the European Renal Best Practice. They recommend once per year testing in high-risk patients. Thank you. Very clear.
Yeah, your slide that with the elephant in the room, that's really impressive to show that how people usually recognize neglect the risk of the kidney health. And the second question is, you mentioned about the UACR application status in Germany now. And do you know the situation in other European countries? And also this question for Professor Delanhette, do you know the situation in Belgium?
Well, it's very poor.
Yeah.
Like Professor Wanner has demonstrated that despite the guidelines, the number of patients that are monitored using microalbuminuria testing is disappointing. And I don't have the impression that things will change. I have the slight impression that the advent of SGLT2 inhibitors might increase the awareness for microalbuminuria a bit, but it remains low. And I think this is also due to technical problems. We are forced to use immunoassays, which are quite expensive. And therefore, I believe that new test strip technologies using CMOS detection should be fostered, so that it could be that it could lower the financial thresholds and therefore contribute to a better popularization. But it remains disappointing.
I have a slightly different hope, not an opinion, it's a hope, because in the moment, you have mentioned SGLT2 inhibitors. Yes, they are becoming generic in the next years, and people will use them more and more. The non-steroidal MRA has to be based on residual albuminuria. And therefore, 3 companies currently are very, very strong, working with massive advertisement, which is Boehringer, AstraZeneca, and the company Bayer. And they promote these assays and they go to every doctor. So I hope with this massive investment, this will change a bit. Otherwise, we have not changed this during the last 10 years. You are correct, Professor Joris. But I hope that with this massive investment, something will change. I will add something. You have nicely outlined the use of microalbuminuria and macroglobulins. The nephrologists, the elderly one, they can interpret and are aware, and they order these tests. The younger nephrologists, they do not use these anymore, and I wonder why. Maybe pressure on the system, pragmatic approaches, or whatever. But I think a panel, this diagnostic panel, would be very, very useful, maybe also in some patients beyond the kidney test. And that's what I have to add here. Thank you.
Thank you, Professor Warner and Professor Delaney, we thought that the issue, the factor, in fact, doctors to decide where to do the test or not is based on the reimbursement of the insurance. So is it that the problem? Is it that the reason that you mentioned that the young nephrologists, they seldom do some tests?
Yes, money is always important, as you know. The tests are better done without extra costs in hospital, because in hospitals have clinical chemistry departments. They can offer these tests, and it's all in the budget. When you go outside, then you have to pay extra, and the situation is different in every country in Europe and outside. And the tests are used, and then reimbursement is not really known to all doctors how it works. And I hope also that more and more these information will convince doctors. You see, the cardiologists, they do troponin T, they do anti-proBNP, and it costs even more. And they just, by guidelines, they hammer this in. Why should nephrology not use a simple albuminuria, UACR, and GFR measurements? Yeah, we are sometimes too shy. So I'm here very strongly advocating this. And the payers in the different countries, they should look after these reimbursement. Otherwise, dialysis is much more expensive.
Yeah, we totally agree on your side. That we rather than put the money on screening and preventing, not on the treatment. And that's back to Professor Delaney. That our second question is, in which condition of the creatinine that you think is not enough to be a kidney function test?
Yes, so there are quite a number of situations where creatinine is not doing its best. So first of all, we have analytical issues. When, for instance, bilirubin is quite high, we see that even when using enzymatic methods, the results are not as good as they should be. So there is already a first technical issue with creatinine. The second one is, of course, the physiological limitations, since creatinine depends on muscle mass. So you can imagine that any situation where muscle mass gets atypical, in cases of muscle wasting, for instance, that we see a falsely decreased creatinine. In that case, I think that cystatin C could be very, very valuable. Also in children, in particular in infants, creatinine values are quite high, are quite low, sorry. And in contrast to the situation in adults, the tubular secretion gets relatively important. So in that respect, there is no longer a relationship between GFR and creatinine. So in young children, I would definitely recommend the use of cystatin C, in particular in case of renal pathology. So these are the most important situations. Of course, any situation where there is a disagreement between the clinical feeling of the kidney function and the obtained GFR would definitely motivate the use of cystatin C.
Okay, thank you for your answer, Professor Delaney, and also thank you for the answer from Professor Warner. As we are reached to our end of today's webinar, I'd like to thank our speakers for bringing today's excellent presentations, and for our audience, thank you for your participation today. We hope you enjoy the webinar content, and you can watch the replay on our YouTube channel afterward on your at your convenience. Please feel free to reach out us with your thoughts, questions, and feedback. Have a great day, and we look forward to seeing you in our future events. Goodbye.